Hello everyone, welcome to Lymphoedema Awareness Week. My name is Kristiana. I'm a consultant in dermatology and lymphovascular medicine at St George's Hospital in London, but I'm also a co-patron of the BLS, and it's my pleasure to give you a talk today about what I think everyone needs to know about the lymphatic system and lymphoedema. And for the rest of this talk, I'm going to turn the camera off so that the slides aren't ruined by my face. In today's session, we will cover what the lymphatic system is, the roles that it plays in health and disease, and then speak a little bit about what lymphedema is, and explore are there any risk factors for someone developing lymphedema. It's also important to understand a bit more about what we can do to support our lymphatic system, and also for the viewers of this talk to understand what information and resources are available to them as clinicians to help them perhaps diagnose lymphedema or signpost a patient with lymphedema to the right place for help. So, what is the lymphatic system? Well, our lymphatic system is this amazing network of lymphatic vessels and lymph nodes that's found in pretty much all the tissues in the body. And this lymphatic system is considered to be the body's cleansing and drainage system. So as I mentioned, it's this network of lymphatic vessels that operate as a one-way drainage system. It sucks up the interstitial fluid, and then when that fluid's in the lymph system, it's called lymphatic fluid or lymph, and it drains that fluid towards the heart. And this system also contains the lymphoid organs, examples of which are the lymph nodes, and the role of these is mainly in host defense, in other words, to help us fight infections. So first up, this lymphatic system has to absorb the excess interstitial fluid that's in our tissues. But some of us may be sitting here thinking, what is interstitial fluid? I don't remember what that is. Well, interstitial fluid is formed thanks to the cardiovascular system, the blood vascular system. So this cardiovascular system pumps blood around the body to supply oxygen and nutrients. And when it moves from an artery into a vein at the level of a capillary, because of the pressures, plasma is forced out into the interstitial spaces. And that basically means the interstitial space is the space in between all the cells. And this fluid is now called interstitial fluid. Reabsorption of this fluid by the venous system doesn't really happen much. It's the lymphatic system that's absorbing all of this fluid from the interstitial spaces. And that's what we refer to when we talk about the revised Starling principle, that this fluid, this interstitial fluid, is not absorbed by the venous system. It's absorbed by the lymphatic system. So in the steady state, the interstitial fluid pressure drives this fluid into the blind-ended lymphatic capillaries in our tissues. We can see in the cartoon here, the lymph system is depicted in green for some reason. And it's close up to the blood vascular capillaries, and it's going to be absorbing all that fluid that's being pushed out of the blood vascular system into the interstitial spaces. And we make about 4 litres a day of interstitial fluid, and that's what's draining into the lymphatic system to become lymphatic fluid. So in this network in our body, depicted on the left in green, you've got all of these vessels that are in the tissues, sucking up this interstitial fluid and draining it centrally towards the heart. And the cartoon on the right is just trying to show you've got the blood vascular system with the blood pumping through the arteries. And then at the level here between the arteries and the veins at the capillary bed, you've got fluid being made that's absorbed by the lymph vessels, going via some lymph nodes, and then it'll drain into the thoracic duct and then get popped back into the heart at the level of the subclavian vein. So this leads us to thinking, what are the roles of the lymphatic system? So let's think about the functions. We've talked about fluid homeostasis. The lymphatic system is vital for maintaining a fluid balance. If the lymph system doesn't drain all the fluid that's being made from the blood vascular system, we're going to balloon up and swell. It's also important for draining cells from tissues. Those could be foreign bodies, those could be viruses and bacteria, those could be cancer cells. And so because it has this job as well of draining things other than just fluid from the tissues, it's draining all these things that could potentially harm us. The lymph system is playing a key role in immune surveillance. The lymph system is letting these foreign bodies be detected by our immune system, and so they can mount a response. We're also learning that the lymphatic system plays a really important role in regulation of inflammation within the body. And it also facilitates fat transport around the body. So if these are the functions of the lymphatic system, this is what it does on a day-to-day basis, what are the consequences of a lymphatic system not working properly? So first off, the consequences of a lymph system that's failing would be lymphedema. And that's the term we give to describe swelling. As you can see here, this lady has lower limb lymphedema. Her feet, ankles, and below knee regions are swollen because there's fluid trapped in there. In someone that doesn't get an early diagnosis and doesn't get proper treatment and is neglected, this is what can happen. You can get elephantiasis, skin changes. So the lymphatic system's really not draining this person's lower leg region, and the skin has thickened. There's papillomas, those pink bumps there. That's because the skin is reacting to the fluid trapped in there. And what looks like perhaps some thickened skin, hyperkeratosis, whilst there may be some of that present, actually most of that textural change on that leg is lymphoria. That's lymphatic fluid that has oozed out through the skin, through the path of least resistance, and dried, forming a crust on that patient's lower leg. So this is something we hope our patients will never have to experience if we can get an early diagnosis for them. Unfortunately, someone with lymphedema or a lymph system that's not working properly is at increased risk of infection. So we tend to think of someone with lymphedema as having a sluggish immune surveillance within that swollen area. The rest of their immune system is pretty normal, but in that swollen area, they're not able to detect that bugs have invaded and caused an infection, and also not able to mount an adequate infection-fighting response. So that's why patients with lymphedema that have cellulitis infections, like this person here on the slide with that bright red, hot, painful leg, they need to be treated more aggressively than someone without lymphedema who's got a cellulitis infection. So how do we manage cellulitis in someone with lymphedema? Well, we advise the healthcare providers to follow the local cellulitis guidelines. Usually that's with flucloxacillin, unless the patient is allergic. But this is where it changes. We recommend to treat for at least 2 weeks, not the usual 5 to 7 days that most guidelines recommend. And that's to ensure that the bacteria are eradicated so that there aren't a few left lurking in the tissues that can multiply and cause problems a few weeks later. And the BLS have created guidelines to help us manage cellulitis in the context of lymphedema, and it provides advice on what to do if the first-line antibiotics aren't working or if someone's having recurrent infections. And because someone with lymphedema is at increased risk of cellulitis and not uncommonly has recurrent infections, we do need to consider the use of prophylactic antibiotics if they're having 2 or more infections in a year. And that's to stop the person feeling unwell from having the infection, because it's pretty rubbish each time you have a cellulitis and you feel unwell, or you're missing work, or you're off school. But also each infection could cause more lymphatic vessel damage, making their lymphedema more problematic, making them more likely to have an infection, so creating a vicious cycle. So for those that are interested, here's a link to the BLS and LSN guidelines on the management of cellulitis and lymphedema. There's a QR code that you can scan here, and these are freely available on the internet for those that are interested in seeing how these patients are best managed. So just coming back to other consequences of lymphatic failure, the big ones are basically lymphedema and infection, but sometimes people can be at increased risk of local malignant changes within their swollen limb. It's pretty rare, but it can happen. So anything that's growing on a lymphodematous limb should be looked at by a doctor to make sure it's not perhaps a skin cancer or something else that needs a biopsy. And another consequence of lymphatic failure is that the lymphedema fluid promotes fat deposition in that affected limb. So some patients with lymphedema will find that their fluid goes from being pitting, and by that I mean you can dent it by pressing firmly with your thumb, to not pitting, and that's because there's not much fluid in that limb anymore. The lymphedema has promoted fat deposition, and so increasing the compression isn't really going to make that limb much smaller, because it's now fat that's deposited in the limb, not really an issue with fluid anymore. So let's talk a bit about what lymphedema is. Lymphedema is the swelling of any body site, and you can use the term interchangeably with chronic edema. Any edema is there because the lymphatic system isn't able to cope with what's being asked of it. And there are many causes of lymphedema. The one that many people have heard of is as a result of necessary cancer treatment. For example, someone with breast cancer who has one or more lymph nodes removed, or maybe some radiotherapy, that will be damaging and disrupting the lymphatic drainage pathways. And so they are at risk of getting lymphedema of the residual breast tissue, the chest wall on that side, or the arm on that side. But there are other causes of lymphedema not related to cancer. So obesity can cause lymphedema, varicose veins, deep vein thrombosis, being immobile, chronic inflammatory skin diseases, certain blood pressure medications that paralyze the lymphatic vessels from pumping. They're called calcium channel blockers. Traumatic damage to the lymphatic system. All of these can cause lymphedema where a previously healthy lymphatic system has been upset by something nearby, disrupting it. But then you also have the slightly rarer type of lymphedema called primary lymphedema. And this is a swelling that occurs in someone with a genetically determined weakness of the lymphatic system. It's probably more common than most people realise. There are hundreds of patients with this condition under the care of the National Lymphoedema Clinics at St George's and in Derby and Nottingham. It can be slightly unusual in that although the genetic weakness is there at birth, often the swelling isn't present when that person is born. It can come on later in life. But typically there's a good family history of it, so it's not something we really need to go and explore for the majority of people coming to us with lymphedema. Usually there's an obvious cause, such as cancer treatment or some of the other conditions I've listed above. So why does lymphedema happen? What's the physiology behind this? Lymphedema happens, so let's think in terms of a swollen limb, perhaps a swollen leg, happens when the microvascular capillary filtration, do you remember that slide I showed you where the blood was going from the arteries into the veins, and from that higher pressure, fluid was being forced out into the interstitial spaces? Well, lymphedema happens when the amount of fluid that's filtered there exceeds what can be drained by the lymphatic system because of one of two scenarios. Firstly, there may be increased filtration, so the pressure might be higher within the blood vascular system, for example, in varicose veins, and it's forcing more fluid out, essentially doubling the workload of the lymphatic system. And it's gone, I'm not working overtime, you're asking too much of me. It fails, and then the person swells. The other scenario is that a normal amount of capillary filtration is occurring, but the lymphatic system can't cope with what's being asked of it. And that can happen in primary lymphedema, where the lymph system hasn't developed properly, or from a secondary cause, such as cancer-related treatment, where the previously normal pathway has been damaged or removed. And sometimes both scenarios can happen. So how common is lymphedema? I think it's incredibly common. At least 400,000 people in the UK are thought to be living with lymphedema, and I personally suspect that may be an underestimate. The more you look at people's ankles when out and about, the more you'll see people that don't have normal shaped feet and ankles. Lymphedema is not that rare. It's as common as Alzheimer's disease, 12 times as common as multiple sclerosis. We know that 1 in 5 people with breast cancer will develop lymphedema as a result of their treatment. And despite how common this disease is, frustratingly, it's really not taught at most medical or nursing schools, and few healthcare providers appear to be interested in it. But I suspect that's perhaps due to a lack of confidence in how best to help the patient that's in front of them with swelling. I don't think it's because they don't care. I think it's because they don't know that they can help this person. They don't know that there is an effective treatment regime, and perhaps they don't know where to signpost that person for help. But hopefully things will change in the future. We are pushing to get it on the curriculum of medical schools and nursing schools. So let's have a think about possible risk factors for developing lymphedema. We can think of this in two ways. Firstly, disease-related risk factors. So is someone going to develop lymphedema? Well, that risk will be increased if they have a disease known to cause lymphedema. For example, breast cancer treatment, where lymph nodes can be removed and radiotherapy can occur. That person, we have a rough estimate of having a 1 in 5 risk of getting lymphedema. as a result of that. Perhaps they're taking medicines that can damage the lymphatic system, but there are other factors that we need to consider. If someone has had cancer treatment and there's no immediate problems with their lymphatic system visually, research has been done on these patients and helped us realize that lifestyle factors, other factors, will affect their risk of developing lymphedema. If someone has an issue with their weight, if they're not as mobile, if they've had a history of varicose veins, deep vein thrombosis, that significantly increases their risk of developing lymphatic problems after their necessary cancer treatment. So this is really important to realize, as patients that have undergone cancer treatment can reduce their risk of developing lymphedema by addressing these factors. So the next logical question to ask ourselves is, how can we support our lymphatic system? How can we reduce our risk? Ensure we have a healthy BMI. It's as simple as that. And it may be that patients that are struggling with weight management need extra support from their GPs. There are new ways to help people lose weight that doesn't necessarily revolve around bariatric surgery. There are weight loss medications which are getting easier to access on the NHS. But then other factors like keeping active, exercising, stimulating lymphatic function by moving those muscles to help pump the fluid out of the limbs, out of the affected tissues and towards the heart. Other ways to support our lymphatic system, I suppose, would be if you've got lymphedema there, treat it. Get that person seen by a lymphedema therapist, get them in good compression garments, or if necessary, some intensive treatment with compression bandaging, and make sure that that lymphedema is being treated, because early treatment reduces the risk of long-term problems. That includes cellulitis, but also impacts hugely on quality of life and other issues. And another factor that's important to reduce the risk of complications of cellulitis is to keep the skin moisturized, keep it intact, to reduce the risk of bacteria entering. So just to prove to you that lymphedema treatment is effective, I want to share the story of this gentleman with you. So hopefully none of our patients will ever find themselves in a situation where they have such severe lymphedema. I'm hoping that all patients will be able to get an early diagnosis and treatment plan moving forwards. But if somebody does slip through the net and has such severe lymphedema as this, then I want to reassure you that it's worthwhile making a referral to a lymphedema team, because the lymphedema therapists can help these people. So this gentleman has lower limb lymphedema. It's worse in his left leg because he's had a deep vein thrombosis in that. So he's got significant venous disease in there as well, creating more problems with his lymph system. He's had recurrent infections. He's also struggling with his weight and he's not very active. So this swelling in his left leg is too big to fit into a compression garment. He's got one on his right leg and that's proving effective, but his left leg is too big and misshapen. So somebody like this needs to have intensive lymphedema treatment with bandaging. And after 6 weeks of compression bandaging treatment, significantly impressive results were achieved, I think. Hopefully you'll agree. So no surgery has taken place here. None of those swollen, lumpy areas were removed by a surgeon. This was effective lymphedema treatment performed by lymphedema therapists. And now the patient needs to address lifestyle factors, work on his exercise levels to maintain the results. So if you're in your day-to-day practice and you see someone with lymphedema and you want to learn more about it, you want to understand a bit more about why they've got swelling problems, or perhaps you just want to do a deep dive into lymphedema and see how we can help these patients, please do take a look at the BLS website. There's lots of excellent resources there. And there are these lymph facts resources. For example, there's a general one on what is lymphedema. And then as you want to read further around the subject, you could understand who has a predisposition to lymphedema and why, and perhaps some of the patients in your care fall into this category. And then there's other tips on what information, advice and support could be provided to those at risk of lymphedema, some guidance on movement and physical activity, and as I've mentioned before, the excellent guidelines on the management of cellulitis in lymphedema. But I also need to give a shout out to our wonderful colleagues at the Lymphoedema Support Network. They can help you or the patient locate their closest lymphedema treatment clinic, and they can be contacted on the phone number here or email. So in summary, hopefully after my talk today, you appreciate that lymphedema is perhaps under-recognized and isn't that rare. Early diagnosis and treatment is really important for people living with lymphedema. Treatment will reduce the risk of complications such as cellulitis, but also improve other areas of their life, psychologically and physically. And please do remember that the BLS is an excellent resource if you want to support the care of patients with lymphedema. Thank you very much.
Margaret, are you all right to just unmute yourself?
Remember the video. So thanks very much, Professor Gordon. That was a great concise overview of the key role of the lymphatic system with very clear explanations. And thank you all for the questions. There's some quite interesting questions coming up, which we'll try and get through as much as we can. If you do have any more, just again, add them to the chat and we'll try and pick them up. So just to get things started, I was just going to ask you, in relation to the patient with very severe lymphedema, are you still seeing as many patients with such severe long-standing lymphedema as you might have done 5 years ago?
Sadly, yes, we are, and it might be for several reasons. I think a lot of obesity-related lymphedema is perhaps on the increase as the general population's BMI is rising. So I think we're still going to see people with lymphedema like that if they're not able to access the healthcare that they need to help sort everything out, weight management and the lymphedema. I still think that we are seeing patients getting a very late diagnosis, and I sadly think it's going to take years before that changes. We need to address education at an early level. So doctors and nurses in their training now, they're the ones that we're trying to make sure we get lymphedema on the curriculum so that moving forwards, there's never someone in the workforce that doesn't know what lymphedema is and doesn't understand the importance of early diagnosis and treatment. But yeah, we're still seeing patients like this, sadly.
Yeah, that's unfortunate. Okay, I have quite a specific question now about how Crohn's disease might affect lymphatic drainage and fat accumulation in the tissues.
Wow, that's a great question. I have to say it's quite daunting being fired questions at. So I'll do my best to answer them. But the disclaimer is I am a dermatologist and who likes lymphedema. I'm not a physician that specializes in Crohn's disease. But so the question was, remind me again.
How does Crohn's disease affect global lymphatic drainage and fat accumulation in the tissues?
Okay, the honest answer is I don't know. There is emerging evidence in the literature that there is a link between the lymphatic system and chronic inflammation and inflammatory diseases. I believe there's been some mouse work on Crohn's disease and a few bits on humans in Crohn's, but I don't think we fully understand this, and we're going to be several years off from it. But we are confident that the lymphatic system plays a role in regulation of inflammation. And I think you could therefore hypothesize that a chronic inflammatory disease such as Crohn's disease is going to potentially upset our lymphatic system, but also the other way around could also be considered. Does some sort of pan-lymphatic weakness increase the risk of getting Crohn's disease as our lymph system isn't able to regulate inflammation as well? So chicken and egg. I think it's such an exciting field, this whole chronic inflammatory disease and the lymphatic system story. And it's also why colleagues like Stan Roxon, I believe, are looking at lymphedema treatment options with anti-inflammatory agents, because I think inflammation is going to be a key target for treatment in the future. So yeah, maybe ask me that question again in 5 years and I'll have a better answer. Okay.
Well, we'll stick with the inflammation theme.
Okay.
You mentioned about cellulitis and needing antibiotics for the full 2 weeks, and that obviously we have the guidelines. do you see many patients whose lymphedema may well have been caused by a failure to treat cellulitis appropriately?
Not many patients,
Okay.
not many patients. I think it is possible that a severe cellulitis could cause enough lymphatic vessel damage that could cause a secondary lymphedema. But perhaps there was an underlying lymphatic weakness that predisposed that person to getting their first cellulitis. And we see that in quite a few of our patients where we've got the luxury of doing lymphoscintigraphy imaging, where we can assess them and see there's actually an underlying lymphatic weakness, a primary lymphedema that predisposed them. And I think actually Prof. Mortimer did a piece of work 25 years ago at St George's Hospital, where they went to the wards and identified patients that were admitted with a severe cellulitis, no diagnosis of lymphedema, and actually found out that many of them had an underlying weak lymph system. So yeah, there's a story there.
Okay, thanks. Someone's asking if do we recommend prophylactic antibiotics if the patient is at risk and has recurrent infections but no lymphedema? And this referred to a patient where compression has made no difference to the frequency of infection.
Okay.
That's a patient
So,
with no lymphedema.
No lymphedema, but at risk. So I'm going to assume that this is someone, for example, that's undergone cancer treatment, breast cancer treatment, maybe, and been told that that limb is at risk of lymphedema because of the treatment they've had. So they're having recurrent cellulitis infections. That tells me that their lymphatic system is compromised because our immune system travels in our lymph system. And they're getting recurrent infections because the lymph system's not working. I think, whoever asked that question, great idea to do compression and see if you can improve lymphatic function by compression. But if in doing so you've made no difference in reduction of infection rate, then I think you do have to go down the route of prophylactic antibiotics and almost treat that person as if they've got lymphedema, following the same guideline protocol, because each infection could cause more lymphatic vessel damage and potentially unmask a lymphedema. So yeah, I would treat them as per the guidelines. And we probably get at St George's, when we're asked for advice about infection things, maybe one patient a year that has no clinical signs of lymphedema, but is behaving like someone that does with their recurrent cellulitis issues. And they do seem to respond to the antibiotic prophylaxis.
Good, thank you. So you mentioned that you have a low threshold for treating leg cellulitis in patients with lymphedema. However, venous eczema can be easily confused with leg cellulitis. How do you strike a balance between antimicrobial stewardship and early infection treatment?
Great question. Yeah, it's really important that we're mindful of our antibiotic stewardship and we don't just throw antibiotics at everything at the first time. I think perhaps I've got the luxury of being a dermatologist as well, so my training in venous eczema is perhaps a little bit more than many lymphedema therapists, but I think you could clinically work out if this is venous eczema that's superficially infected, not a true cellulitis, versus a true cellulitis. So a venous eczema would be there would be epidermal change, there would be textural change, it would be scaly, flaky, itchy. There would be other clinical signs of venous disease, so hemosiderin deposition, atrophy blanche, maybe some early lipodermatosclerosis, and then asking the patient, are you feeling feverish and flu-like? And if they say, no, my legs are just red and hot and I've been treated for cellulitis repeatedly, you could sort of be more comfortable going, I think we need to go down the eczema treatment and the compression treatments rather than cellulitis treatment. And I therefore, if someone is systemically well with no history of fevers or malaise, and I'm not certain that it's cellulitis, I would optimize their skincare and do something like Fusobet with a steroid and antibiotic if I felt it was slightly impetiginized and weepy, rather than always rush in. But I appreciate it can be difficult for therapists without that dermatology training. And I think if you think that someone is having a cellulitis infection, then ask for a second opinion from a medical colleague if you're not confident in starting the antibiotics yourself, because we don't want to miss a cellulitis.
Yeah, I think it might also be worth looking at the British Lymphology Society in lower limb inflammatory pathway, which does try and it's a guide to how you might diagnose or determine whether it is cellulitis or not. So worth looking at that, and we'll try and get that link up in the chat. Okay, somebody's asking, you said 1 in 5 women get lymphedema after breast cancer. Would men be included in that statistic?
Yes, they would, but men get breast cancer far less frequently than women, and are therefore not included in the data as such. So I can't say for certain they have the same risk, but it's in breast cancer, we believe it's in breast cancer related lymphedema, it's several different factors that lead to the person developing lymphedema, and the majority of that relates to lymph node removal and radiotherapy and medical therapy. And as far as I'm aware, for the surgical side of things, that's the same between males and females.
There's a couple of questions about whether lymphedema can be caused in cancer patients other than by removal of lymph nodes, and a related one about somebody asking if some chemo regimes increase the risk of lymphedema.
Some great questions we're getting today. Yes. So cancer treatment, depending on what sort of cancer it is, often includes removal of a lymph node, such as the sentinel lymph node. And if that's positive, then the surgeons might want to go on and take more lymph nodes. So perhaps we would call that a regional lymph node removal, where lots are taken. And then again, depending on the cancer and the stage, they might consider doing some radiotherapy as well. All those three procedures there carry a risk of lymphedema. So, and it's because of the physical disruption of the lymphatic drainage pathways. I can't remember the figures off the top of my head, but I know that the rates of developing lymphedema differ depending on how much treatment you have. So the risk of getting lymphedema after a sentinel lymph node biopsy, for example, in the treatment of melanoma skin cancer, might be as low as 5% risk. But if that patient has to go and have complete clearance of that node basin, then that risk would increase to maybe 20% or more. In someone with breast cancer related treatment, having axillary lymph node clearance and radiotherapy, there are some papers stating the risk of lymphedema after that can be as high as 60% or more, depending on some papers. So what you have, I think, affects your risk. And then I think another part of that question was, is there anything other than lymph node removal that increases the risk? Yes, some of the chemotherapy agents do increase the risk of upsetting the lymphatic system and causing lymphedema. I can't, be specific about the names on here, but I'm sure that there's some guidance somewhere as to which ones, and I'm sure our oncology colleagues are very well versed as to which ones are the more likely culprits. But at the end of the day, that person needs their cancer treatment. That's got to be the priority. And we, as the lymphedema team, will support the lymph system after that cancer is cleared.
Yeah, and I suppose it's important to remember that there are other risk factors like inactivity or being overweight. So we want to do as much as we can to help people not to gain weight or to maintain a healthy diet, that kind of thing, to reduce the overall risks.
Absolutely. And I think in the future we'll also be aware of genetic risks. So there's a couple of papers out there suggesting that patients with an underlying primary lymphedema that they didn't know they had would mean that they're more at risk of getting breast cancer related lymphedema. So
just what I will say at the end, but there is a webinar on breast cancer related lymphedema and breast edema tomorrow if anybody wants to drop into that. Going back to inflammation, can you explain a little more about the role of regulation of inflammation by the lymphatic system, and subsequently, would lymphedema cause inflammation in the body?
So that's another great question, and is quite similar to the one about Crohn's. So my answer is going to be pretty similar, and hopefully I am repeating myself and standardizing my answers, that there is this emerging realization of a complex link between the lymphatic system and the inflammatory regulation system. So chronic inflammation has been shown to upset lymphatic vessel function, and also the other way around, lymphatic dysfunction can cause lymphedema. So there's some very nice work. I think Babak Marak has done some good work there demonstrating there is this link between lymph system and inflammation.
Okay. It's something a bit different. How successful is lymph node transplant treatment these days?
I'm not a surgeon. I'm going to bounce that one. I think perhaps we could, in future years, invite one of our surgical colleagues to come and give that talk. I think if you look at the literature, the results seem to be very variable. I'm sure it will come down to patient selection as to who's going to be the more likely to respond. You know, a lymph node transfer procedure in a primary lymphedema patient is far less likely to work than someone who's got their lymphedema after a cancer treatment scenario where the lymph pathways have been disrupted. And then also, you know, other factors such as that patient overweight, are they active? That's also going to influence whether they're successful or not. And another thing that the literature is not very good at doing, or perhaps the surgeons presenting their work, is commenting on whether those patients are also receiving lymphedema treatment with compression at the same time, because I'm sure that if they are using compression, that will influence outcome as well. So, yeah.
Okay, does lymphedema generally cause pain in the area of swelling?
Depends on the definition of pain. Having been doing this job for 20 years now, I have some patients that say, yes, my lymphedema is painful, and others go, no, it's a bit heavy, it's a bit achy. I think it, you know, a lot of it's going to relate to that person's perception of pain. Yeah, I think it can be painful. You know, especially if you're having an acute flare up of swelling, everything's really swollen and tight, and that's going to upset nerve endings as well. The other thing is, I think pain's also a clue about cellulitis. If you've got someone with a sudden change in their, you know, how they experience their lymphedema discomfort or pain, and it's got worse, I would be considering whether cellulitis has complicated things.
Okay. Okay, this is a bit of a loaded question, but you've had it before. Someone's saying that they're interested in hearing about how we can consider inequalities in access to lymphedema care for patients without a commissioned service, for example, in mental health inpatients, and as mental health providers, what can we do to help our patients? It's great that we've got people who are mental health providers on this call.
It's brilliant, isn't it? It's brilliant. It's such a difficult subject, this. I just wish that all patients with lymphedema could all access the care that they need quickly, wherever they may be in the country. But yeah, we're not there. I mean, you know, as you know, we've tried to take things all the way to Parliament and fight for this, and it's not been an easy journey, and we're still battling. I don't know how. There's no quick and simple answer to this, but I think education is going to be key, and that's going to be education of patients, but more importantly, education of healthcare providers in all specialties. You know, mental health care providers. It's fantastic that they're on board today, and they're recognising that there are patients here with an unmet need, and they're asking how they can get involved and help. So, you know, thank you for joining us, and thank you for being interested. And I think, you know, if we can spread the word about the BLS and our information documents that can just help people guide these patients to the right places, we will improve things compared to how they are now. But obviously there's a long way to go before we're at a level where everyone is getting the right care.
But I think probably just also being aware of the simple things that you can do, the skincare that you mentioned, the being active, that kind of thing, and trying to refer to someone as early as possible.
Definitely, early treatment is key.
Yeah. Is there any research which shows how individuals from Black, Asian, and global majority are impacted? Not quite sure I understand that, but I think it's probably about how it affects different cultural groups.
I don't know off the top of my head, I'm afraid. I'm sure a PubMed search would reveal something.
Okay. Please could you explain the difference between lymphedema and lipedema?
How long have we got? It's not an easy one. The short and sweet answer is that lymphedema is an increase in limb volume due to accumulation of lymphatic fluid, whereas lipedema is an increase in limb volume due to an accumulation of fat tissue. It's far more complicated than that, and some women with lipedema will also get lymphedema for reasons we still don't completely understand. Yeah, I'm not sure I can give the full answer to that one, because I don't think we have the time or know all the answers. But if the person asking that question wants more information, they're very welcome to get in touch, and we can signpost them to some resources.
And there is also a fact sheet about lymphedema
There is,
on the There's quite a few more questions. We're not going to have time. I'm going to ask you a couple that I think you could answer quite quickly. I've seen advertised a kind of vibrating foot plate. Are these viable for lymphedema management, especially those who are not able to mobilise easily?
How do I answer this one? I think the trouble is with many of these products that are out there is they don't appear to have been robust clinical studies done on them. So I can't say that there is convincing evidence that they are beneficial. However, patients will come to my clinic and say, I've got this and I've used it. And some will say it made no difference. And others will say, actually, I do think it sort of softened things. I don't think they're going to do any harm. So if somebody's already purchased it and feels benefit from it, I'm supportive of them keeping doing it. And if it does encourage them to move more, then that's a great thing. But I'm not at the stage where there's enough evidence saying to me that they work that I'm going to be recommending these sorts of things to patients to go out and buy.
Okay. And should an obese patient with lymphedema expect the lymphedema to decrease as weight decreases?
Yes, they should. They should. Definitely. So in our clinic, we say lymphedema is a chronic disease, and unfortunately we can't cure you, but we can improve you with compression. We've actually had 6 patients that had lymphedema purely because of their obesity that have successfully lost all their obesity weight and come back to clinic and said, look, my lymphedema has gone. That's not the norm. Many patients with obesity-related lymphedema will have a degree of long-term lymphedema, but in some cases you can, in theory, cure your lymphedema if it's weight-driven and you lose the weight. So yeah, swelling will improve with good weight loss.
Okay. I think we probably have to stop badgering now and draw the session to a close. There are more questions. We will try and maybe answer these or direct people to where they can get information for questions that we've not answered yet. But thank you once again. Thank you everyone for joining us. And just want to draw attention to tomorrow's webinar is by Dr. Katie Riches, and it's about breast cancer related lymphedema. And also for any non-lymphedema specialists who've joined us today, you might be interested in a new free Introduction to Lymphedema Study Day that's been held on the 6th of October at the Chester Racecourse alongside the British Lymphologist Society conference. So the study day is designed to try and help you to be equipped with the knowledge and confidence to spot lymphedema and provide supportive care and collaborate effectively with specialists. So I think the chat will have the link to register if you are interested, or please share it with colleagues, and it will go live on our website in April. So thank you very much once again, and so we will try and give information if we haven't answered your question. So thanks again, Kristiana. Lovely to have you. Okay, and please spread the word for Lymphedema Awareness Week.